think live stream has started.
Yes, Tirumurugan sir would have done that. Thank you, Dr. Tirumurugan.
Thank you. Yeah, sorry, just 1 second. Yeah.
No problem. I think you're traveling இல்லீங்களா?
இதுவா இருக்கு பரவாயில்ல நீங்க கண்டினியூ பண்ணுங்க ஒரு நிமிஷம் I'll make it the host.
Yeah.
Yeah, I made it the host. Okay.
Yeah.
Thank you.
Thank you. So it's about 7:32. Can we start the program? I think Dr. Manoj also wanted to go a bit earlier.
Yes, ma'am. We'll start the program.
Yeah, we'll start. Okay. So Dr. Sundaram, our President IAP TNAC is coming back from the base module in Trinelveli. He's at the airport in the flight, so he might not be able to join. But apologies on his behalf. But we will start the program. We will start with the pediatrician's prayer. Pediatrician's prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love and peace to all children and their families, irrespective of the status and creed. Give us the wisdom, understanding to change the things we can, retain the good and accept within reasons the things we cannot change. Grant us your blessings, grace and mercy in all situations, at all times and amidst all people. So I now on behalf of IAP Tamil Nadu State Chapter, me Dr. Narmada, inviting you all for this wonderful program on CME of the subspecialty chapter. This is the third program of our state, and first two was from infectious diseases, and we now are having from adolescent chapter. And we are going to have a very interesting discussion on topics that are of clinical relevance also now. So having said that, it's a pleasure to have you all on this dais, and I request our State Vice President Dr. M.S. Vishwanathan to say a few words. M.S. Vishwanathan sir, over to you.
Good evening everyone, welcome. And on behalf of IAP TN, let me greetings to President Dr. Somsudaram, Dr. Rajendran, Dr. Thiru, Dr. Rajkumar, and academic Dr. Manohar, and this is the faculties today, Dr. Manoj Sharma and Dr. Naveena, Dr. Eba Chanardharan, Dr. Lakshmi Chandi, Dr. Pradeep, and the adolescent chapter office president Dr. Aram Sandil, Dr. Lakshmi Santi, Dr. Amuda, and Dr. Naveena Karthik. Welcome you all, and I think as Dr. Narmada mentioned, this is the third subspecialty CME, and so every month ஒரு மாதமும் ஒரு சிறப்பு மாதிரி நல்லபடியா போயிட்டு இருக்கு. So let us go ahead with this program today, and I'm sure everyone will rock today. Thank you.
Yeah. Dr. Tirumurugan, are you in a position to give the felicitations?
Yeah.
Thank you. Over to you, our President-elect, Dr. Tirumurugan Sireen, who is a very technical person and a very big supporter of all the programs and a very enthusiastic person. Over to you, Dr. Tirumurugan.
Thank you, Dr. Narmada. It's really delighted. I'm really delighted to see this monthly CME of subspecialty chapters of IAP TN. As we all are aware, IAP subspecialty chapters have really started showing strong roots and then growing in great manner in Tamil Nadu for the past couple of years. And AHA has been at the forefront even before this movement has started happening. And it's very appropriate that our AHA chapter has now conducting the third monthly program on something which is very, very relevant for us today, which is about the internet addiction. And we have to really some eminent faculties in Dr. Manoj Sharma and Dr. Deepa, along with the rest of our AHA people taking part in this very nice webinar. So I wish them the best success, and I'm sure everybody will learn and enjoy from this event. Thank you very much, Dr. Amada.
Yeah, thank you so much, Dr. Tirumurugan. Dr. Manohar sir, academic coordinator, sent his wishes, and he is also out of station today. But we know that this program has been watched several times in the YouTube, and last developmental CME chapter also was taken up in many of the viewership in the YouTube, and I'm sure this CME would be a very interesting and very important one for all the pediatricians. Having said that, you are very correct, Dr. Thirumurugan, that the adolescent chapter has been in the forefront, and this year it has been very, for the past 2-3 years, they have done a lot of community activities under the chairmanship of Jayashri Madam, Sendil, and Lakshmi Shanti at the forefront, and Amda joining with them. So now we have Dr. R.M. Sendil, who has joined with us, sir, for a few words, and I will be handing over the session to Dr. Amuda, the Secretary of Adolescent Chapter.
Yeah, thank you so much, Dr. Narmada. It has been really a great evening today. We are going to have wonderful discussion on social media, the internet trap, by Dr. Manoj Sharma and Dr. Deepa Janardhan, the adolescent expert from Kerala. And of course, Dr. Manoj Sharma is running the Shut Clinic in Nimans. He's a professor and HOD there. And it is nowadays this mobile and screen addiction has become not only a hot topic, it is becoming an epidemic and problem. I mean, students are facing a lot of problems, and parents are having difficulties in managing them actually. So definitely, this is going to be the need of our. Of course, there's going to be a panel discussion on problematic internet use, and that is going to be with Dr. Manoj and Dr. Deepa, and of course our own Dr. Pradeep and Dr. Navina. So this is going to be a useful CME because nowadays, as pediatrician, we require a holistic approach because infections have come down. We are going more into developmental pediatrics, and of course, everyone has to understand the adolescent component also. And adolescent have so many problems, and definitely, adolescent chapter is doing a wonderful job in Tamil Nadu. So definitely, our aim is to do more of community programs, and of course, we need to concentrate on pediatricians to let them have the connect with adolescents, and of course, parents and teachers, they also have to be definitely looked after. So thank you for the opportunity, and now we'll go to the necessary topics.
Thank
Thank
you,
you.
sir. Dr. Lakshmi Shanti, our Vice Chair, do you want to say a few words, Shanti? Okay. Now I hand over Dr. Amuda, our secretary, and doing an excellent work. Please do take over the further proceedings of the CME. Over to you.
Thank you, Narmada ma'am, charismatic leader who always inspires us. Good evening, and a very warm welcome to all the esteemed dignitaries and respected faculties and dear colleagues. I feel honored and privileged to host this evening. I would like to invite current chapter. Sorry for the interruption. Now, without further delay, we will move on to the session. As pediatricians, we are increasingly seeing the digital world having an impact on the mental and physical health of our young patients. Today, we delve deep into the crucial topic, understanding and managing the internet trap. Before we begin, quick house rules. Please keep the microphones muted. Feel free to post the questions in the chat box and we will address them during the question and answer session. At this juncture, it's my great pleasure to invite our esteemed faculty, Dr. Manoj Sharma sir, Professor of Clinical Psychology, NIMHANS, Bangalore, who is notable for starting the India's first tech de-addiction facility, the Shut Clinic, Service for Healthy Use of Technology. He is a member of the WHO expert group on addictive behaviors and Lancet group on gambling. Sir is recipient of WHO Fellowship in Tobacco Control and also ICMR DHR Senior Scientist Fellowship. Sir has over 230 research papers to his credit. He has been raising awareness about the impact of technology used in various national and international media. We are indeed privileged to have you here, sir. The virtual floor is yours. Sir, please.
Good evening to all of you, and thanks for inviting me and to share my experience in this area with all of you.
Any issues, sir?
Just 1 minute.
Yeah, sure, sir.
It's okay.
Your slide is not visible yet. It's now only visible. Yes, sir. Can you move the slide and see?
Just share again.
Yes, sir. I think you have to put it in screen show.
So I think today's what we are suffering from is what we call fear of missing out something. And that's a reason for excessive use of technology because we keep our mobile phone 24 into 7 with us because either we want to respond to whatever has come to on our mobile phone or we want to update ourselves with whatever is happening around us. And that's also become the reason to delay our sleep also because most of the people, whether adolescent, adults, or older people, wants to sleep with a mobile phone, wants to sleep with social media, wants to sleep with show series and other things. And that automatically delay the initiation of sleep also, and which definitely affects the next day productivity also. And the foremost has come because of accessibility of mobile phone. Post COVID has seen everybody has access to one or the other devices and the devices accessibility has increased, affordability has improved, and that's why people are most of us do suffer from fear of missing out something. So I think the overall journey which we have to target is we have to build up joy of missing out something, which we say joy of missing out something, which is a mindful state we have to achieve. So I think we have to learn be without the mobile phone. We have to learn to enjoy our offline interactions. We have to learn to sleep without mobile phone. So I think this is the whole journey which we have to target from fear of missing out something to joy of missing out something. And based on our research and experiences, because there was no service until 2014 in Indian context, so we started this clinic which we call Service for Healthy Use of Technology. And it was first of its kind initiative in Indian context as well as in Southeast Asia, and which received a lot of media attentions, as well as policymakers were also interested to work in this area also. And that's why I think recently even Karnataka government has brought out a digital policy draft for healthy use of technology. And there is a Chief Minister of Karnataka has also proposed a social media ban. The details of it has to come, but I think that's another initiative Karnataka government has taken for healthy use of technology. Why it is a concern for us? I think till now, I think we spend in 2024 and all, we spend almost like 1.2 trillion hours on mobile devices. The reason goes because on an average, we check our mobile phone 60 to 70 times a day. And sometimes it is for professional purpose, sometimes it is for recreational purpose also. And especially adolescent, it is more because there is a lot of peer recommendations, peer pressures remains that I have to see and respond to all the messages. And that's why I think another phenomena which all of us do suffer from is called double click syndrome. Once you send message to anybody, if you don't find double click in your mobile phone, all of us get disturbed. That other person either has not seen your message or is not interested to respond to you. And sometimes it create anxiety in the first person, and sometimes they do send 2 3 messages also to attract the attention of the second person also. So that's another thing. And that's double click syndrome also makes us a heavy user of mobile phone. And 45% of the global population, I think, check almost like 60 to 90 minutes we spend on YouTube videos. Nowadays, Reels has come, short videos is very popular because all of us do not want appreciate what we call delay of gratification. We want immediate gratification. That's why the Reels, short videos has catched up among adults as well as among the adolescents and children population also. And generally, it's seen like it's not adults. Screen use is a problem, but frequent accessing multiple apps and other things also affects the cognitive functions. Like anytime when you're doing focus tasks, and if you distract yourself to see any content online, your brain takes almost 3 to 5 minutes to reach back to the same concentration level. So that's why I think maybe the reason among children and adolescents that they are losing out their academic grades because they frequently distract themselves to respond or to remain engaged with online platforms. And what is other things which is happening is YouTube has made a lot of things easy that we can pick up a lot of things from YouTube to do certain things and all. Nowadays, is whether it's a YouTube or there is AI or Chat GPT, it is a help. But I think are we using in a productive way? But I think if you see somebody does surgery on watching YouTube videos, not advisable. And I think even if you see this is a study is News 18 that almost 75,000 people who are in the 18 to 20 they were explored and they found the severe distress is related to smartphone or ultra processed food also. Increased screen time has also contributed to social withdrawalness, hikikomori. Generally, most of the family complains that my son or daughter always remain with the screen. He or she doesn't want to interact. She doesn't want to spend quality time. Or he or she, even if we take them to any social situation, they prefer to select a place where they can spend time with the mobile phone. So that sort of social withdrawalness has come up. In this direction, another things which we has to notice what we are now seeing is which we call technoference. Or technoference is how technology is interfering in interpersonal communication, how technology is interfering in interpersonal relationship. You might have seen that sometime one family member complains to other that you are too much into technology, you are not paying attention to whatever is happening around you, or sometimes you are not interested to even for important discussions and all. So if that is there, that is cause technoference, and sometimes it is a issue among young couples also, as well as I think sometimes it is a concern for adolescent also. They don't pay attention to whatever parents wants to convey them. They remain with the mobile phone. And another thing which has come, which the Karnataka government has taken decision in terms of digital policy is like they have seen a lot of suicide in last 3 years because of gaming related issues. That's why they feel there should be some policy, some restrictions so that children can be motivated for healthy use of technology. Another thing in the psychiatric population, which we are now seeing is most of our clients do prefers to take online help. And now earlier it used to be online help. Now they feel even AI companion or AI chatbot can also help them. And they generally look for validation of various emotions rather than talking to any professionals and all. And that are sometimes because AI has a merit that they validate your emotion, but whatever you ask them to validate. But when you seek any professional help, they will see in a holistic way. But that's the difference. But I think most of the people don't want to seek professional help and they likely to bank on either YouTube videos or AI companions platforms, which is it shows some positive result, but it's not always healthy also. So why is it a concern? I think though we have a lot of guidelines by WHO, by American Psychiatric Association, even Indian Association of Pediatricians has brought out guidelines, but still this is the pattern of use we have. Even children as young as 0 to 2 years have 49 minutes of exposure to screen. Sometime when they are fed, sometime when they are into any activities, parents do expose them to technology use. As they grow older, I think if you see by age of 8 and 12 years, they almost spend 5 hours a day, which is as per WHO recommendation, it should be less than 1 hour. But I think it is goes almost like 5 hours a day. And IAPR also says 11 to 17, it should not be more than 2 hours. But I think again, it is much more beyond that recommended guideline. So somewhere the criticism also comes that though we have guidelines and recommendations, but we have not proposed skills how to implement those recommendations to day-to-day life. Because most of the parents also complain that guidelines are there, but what as a parent they should do? Because most of the parents have a problem in negotiation, how to negotiate, how to communicate for negotiation with a young child for mobile phone as well as for controlled use of screen. So that's why definitely there is a need to work on guidance based manuals, protocols for parents also, which they can use to for negotiation and for communication related to healthy use of technology. And another concern which comes up, it's not a problem of children, even adults in Bangalore region we have found, they have almost 7 to 12 hours of use, which is a very high use. I think sometimes it is for professional purpose, sometimes it is for recreational purpose. So if adult has such a heavy use, definitely you can count definitely estimate that there would be 50% use in the children's also, because they will find that all adults are busy with the technology and there is no other way out to spend their free time as well as to overcome their boredom. So in case if we have to work with children's, we have to work with adults also. So it means it definitely demands multi-dimension stakeholder approach to work on healthy use of technology. But technology is always not bad. I think what we have found in our studies and all, if the children have or if we promote whatever the recommendations are, definitely it will have positive impacts on cognitive functions as well as on interpersonal and other domains. But why it is a difficult things to quit? I think there are some phenomena which you must understand. I think which is sketchy phenomena, which if you discuss, it will make a lot of impact. And one is nomophobia. Most of the children or the users feel that they feel anxious if they're not carrying their mobile phone with them. So if that is the anxiety they experience, definitely shows their excessive or preoccupation with technology use. Phantom vibration syndrome refers to, it has come like we earlier in psychiatry, we have pseudo hallucination. Phantom vibration refers to pseudo vibration of mobile phone. Sometimes you feel that phone is vibrating, you feel notification has come, you feel some message has come, but when you check your mobile phone, there would be nothing in terms of notification and messages. But if it is happening frequently with you, it is also a sign of overuse of technology. Zero inbox syndromes refers to tendency to make your inbox zero, and that also allows you to repeated checker of mobile phone. Fear of missing out something we have already discussed, but in fear of missing out something is also what another syndrome which is coming up, which we discuss in terms of chair life or chair use syndrome. Nowadays, people use chairs for a long period of time to remain with the screen. So when you are using screen even for professional purpose and long hours sitting is there, so definitely you are putting yourself at risk for musculoskeletal issues, or you are putting at yourself at risk for digital burnout. So definitely there is a recommendation that after 30 to 40 minutes of sitting, you must take few minutes break, stand up, move around, so that I think you can reduce the chance of musculoskeletal issues also. Self-it is still not a clinical condition till now. Only internet gaming has come as a clinical disorder, but some guidelines has come even for self-it use, like because nowadays people are putting themselves at risk for use of for taking selfies and all. So now that till now the recommendation has come that if you are taking more than 3 selfie a day without any reason, then definitely it's a sign of some body image issues. It is also a sign of some underlying psychopathology, or you may be looking for some appreciation and other things, or you may have a need for more followership and all. So if there is no reason to take selfie, then avoid it. I think that should have, information should go to the adolescent also. Social media fatigue, like long hours to remain because of FOMOs, we remain on social media, definitely cause fatigueness, which leads to uh, feeling of exhaustion and which also affects the productivity in other domains also. Binge watching is another thing which we have to address. Nowadays, all of us have a habit of watching show series, and sometimes the show series are planned in such a way that they have a element of to retain or attract your attention for a longer period of time. And sometimes all of us do cross more than 3, 4 episodes in one sitting. But now the criteria is there that if you are watching any show series and more than 3 episodes in one sitting, then you are suffering from binge watching. And binge watching has also come from addiction, like where we say binge drinking. So now it has become binge watching more than 3 episodes in one sitting, or more than 120 minutes of recreational use in one sitting. If that is happening, then definitely you need to take a call, or you have to advise others to take a break after first or second episode, so that their control aspect of the brain remain intact. Now, virtual spectrum disorder or computer vision syndrome, these are the things which long hours of use contributes to. Then comes another thing, which is there is smartphone lavatory syndrome. Nowadays, I think most of the parents do complain the child takes the mobile phone to the restroom and he remains in the restroom for hours together. And for the child, it's become restroom become the space where he feel there is no disturbance and he can browse or do whatever he wants on the mobile phone. But now the criteria has come like, and it also puts them at risk for various medical conditions also. So now the criteria has come like if you're using more than 20 minutes of mobile phone in a restroom, then definitely it's a sign of loss of control which needs to be attended. So another thing has come, like these are one model we have developed which we call Maslow's model. Maslow's is like 5 needs which are required for human development. But now we are saying that all these needs are also getting expressed or compromised due to use of technology. People are not so much worried about fulfillment of physiological need, but they feel that I can't survive without mobile phone. So, and that's why that's a reason of behavioral disturbance in children's also. So I think that way the first need is also getting expressed to technology use. People feel better safe if they're carrying their mobile phone with better recharge, which is a common thing also. But if it is become too much, so more or less you are replacing that basic need of safety with technology use. Social needs, now children are more comfortable with online friends. Children are more comfortable with online relationships, and they feel there is no need to go out and talk in person or to spend time in offline context. So more or less that need for affiliation, which is common, a human need, get also fulfilled through online platforms. Self-esteem comes up in terms of likes, in terms of followerships and other things. And what we have seen, that all your social media content, all your follow-up will not be there when you are in a crisis moment, because they will be there as long as you are active on social media platform. And we have seen first, if you check your contacts, only first 50 contacts will be the genuine contact who will be worried about you, who will be distressed if you are not there or active on social media platform. Self-actualization, still we have not picked up the right expression. I'm open for any suggestion. What can be the self-actualization expression in relation to technology use? But people don't want to come it out. People don't want to remain stuck. So it may be that somewhere it is also fulfilling this need for self-actualization. But right expression we have not found till now. So all these basic needs are also getting fulfilled through use of technology, and which definitely is the reason that's why we are facing issues in balanced use of technology. We are facing issues in implementation of strategy-based suggestions also. And now another things comes up, what technology is promoting is because of anonymity, it is also promoting what we call internet regression. Regression is a dynamic term which we use in psychology, which sometimes comes in disorder like dissociation and other things. But in internet, because of anonymity, people do start exploring a lot of deviant side because they feel nobody will notice them, nobody will check with them, and they feel that whatever I do I can delete the history also. So if this kind of illusions creates lets them to explore various deviant sites also, which know termed it as like internet regression. And there is another term which we have to sensitize our young children and adolescents, which we call cyber laughing. Cyber laughing is most of our children are active on various platforms while doing their focus task. But what happens when they are on any focus task, suddenly if they find a pops up on social media or any reels, they stop the focus task and they start watching reels. And once they finish one reel, they will go to the other pops ups and other things. So that way they will get into other online activities rather than finishing their focus task. So if that is happening, this we call cyber loafing, which again we have to sensitize young children that if they are on uh, focus task, that time I think if they can reduce their technology use. Hikokomori I have already discussed. It refers to social isolation, which all of us are experiencing because of preference for online activity. But the reasons remains 3A: anonymity, accessibility, and affordability. If we find the answer to all these three things, I think we can definitely go for balanced use of technology. And what does it all leads to? It leads to loss of control over use of technology. It's become prioritized activity for you, and you continuous use despite consequences, which may manifest as problematic or addictive. We find only 3%, 3 to 5%. The majority will be in problematic zone where they have problem, but still they have a reason also to continue with it. Then I think some of the other symptom which comes because of post-COVID, most of our leisure time activities have become digital. That's why the use has increased. Digital failure is another things, like how do you feel when net connectivity is slow and when there is no net connectivity? Most of us don't feel comfortable. That feel that we start exploring that where I can get more net connectivity. So if that is happening with you, that is we call digital failures. Digital burnout is because of professional reasons you are on technology use, and because of long hours of screen use, you are facing fatigue, exhaustion, and decreased productivity. That we say digital burnout, which is different from digital addiction. And these are some of the psychiatric condition which we commonly find and which you have to screen also whenever we are doing any therapy work with the children for technology use. We have to check for ADHD. We have to check for stress, anxiety, and low mood state, which is common in most of the users. And we have to look for neuroticism and conduct disorder. Even Parkinson disease, we have found that because of dopamine things, they're also into gambling and other things because of biochemical changes. But these are like some of the negative mood states which mediates your excessive use, which you have to screen out and provide solutions if you have to work on screen use, which include sadness, anxiety, fear, anger, guilt, boredom, and disgust. And these are your individual because sometimes it's advising is okay, but I think sometimes there is also individual reasons also to continue with the technology issues. Like if the child feel that I'm worthless offline, I'm not doing very great in my schools. I'm not doing very great in sports, but I'm very important online. All my online friends recognize me, acknowledge me, and I feel okay there. If that is the belief they have developed, it's we have to target those negative thought process also. And maybe I think other cognition comes. I'm a failure in real world again, which will prompt the adolescents towards excessive use. And I think you might have seen most of the adolescents know how to make YouTube videos. They know, and they already have some YouTube channels, and they also knows how to that YouTube this kind of YouTube videos can provide them careers and all. Even children as young as 12 and 13 also have a clear opinion. So if this kind of opinions they have, I think we have to sit with them, guide them in a proper manner. And I think sometimes this cognition world doesn't care for me, so I might myself immerse in online world. And sometimes it is blaming also another error which comes. It's not internet, it is a stress in my life which I am working, managing through use of technology. I need internet to deal with my problem in my life. My parents, spouse, and school drives me to the internet. Or sometimes it has been a long day, internet helps me to relax. Sometimes it comes like weekend choose are more than working days because people feel that weekends are mine. I can do whatever I want. And they plan that
That's it.
it's like a similar sort of planning happen which we do for substance use that I will have a drink after the post 11 or 12. But again, similar sort of planning we build up for internet use also. Rationalizing like internet use is not as bad as having alcohol. This is reward for my hard day work. Or sometimes people do have a minimization error that is just smartphone, nothing much I can control anytime. But that control never comes. Or gaming is not as bad as any kind of other addiction. I think these are the recommendations you may be already familiar, so I will not go into. So what most of us, because there is no absence of significant skill-based recommendations. So generally, I think these kind of terminologies are also happening in media world as well as in as a recommended as a strategy, which we call digital detox, digital fasting, digital minimization, or dopamine fasting. These kind of things always refers the same content that we are working for healthy use of technology. So now I think if you have to promote digital hygiene, I think this is the common thing. Assess yourself for use of technology. There can be three categories: recreational, problematic, or addictive use of technology. And we have to see when this use become problematic, we have to be conscious of, and when the problematic become addictive, again we have to take individual actions or we have to take professional help. And these are the assessment which you can do in home setting as well in your clinic setting also. This is called 5C criteria. Answer can be in yes and no. The first is craving. Do you feel continuous desire to use technology? Yes, that's the first sign toward addiction. Second is control. Do you have a experience loss of control whenever you initiate any online activities? If that is also there, that's a second yes toward problematic or addictive use of technology. Third is coping. Are you using technology to relax or to feel good or to overcome low mood states? If that is there, that's the third yes. Fourth is compulsion. Has it become a habit for you? You keep checking your mobile phone even though there is no reason for it. And the last is consequences. You have health, academic, and professional consequences, but still you are continuing to use it. So out of 5C, in your brief interview, if you find all 4 years or all 5 years, then definitely there is a need to educate the adolescent or to educate others also. This is another smallest screening which you can use in clinic settings. This is called CAGE. Again, it has been taken from substance use. The C stand for do you feel a desire to cut down your smartphone use? Do you feel annoyed due to your smartphone use? Do you feel guilty for your smartphone use? And do you start smartphone as a first thing of the day. So if all minimum 3 years, if you find, or all 4 years, then again this is a sign that there is a need to give advice to the adolescents for healthy or balanced lifestyle, because adolescent may not accept the advice of quit technology, but adolescent may accept the advice of increase engagement in other activities. So engagement can come in physical activities, engagement can come in family-based activities, engagement can come in other social relationships. So work on engagement, and this can be the simplest screening which you can have it in your clinic setting. This is another thing. So beside these two, I think if you want to have further assessment, this is 10-item scale, smartphone addiction scale, which we have validated in Indian context, which again can be used to have more better information. And the score, if it is above 34, it shows addictive use of technology. And this is problematic pornography consumption scale, because this is pornography has become a problem even among adolescents. 13, 14-year-old adolescents also do accept that they had watched or discussed pornography in peer setting. So I think that's why it's better to screen out this use also. And we have seen in this scale, and if the person has a score of 76 and above, then it shows problematic pornography use. So now the next things come, the simplest suggestion includes that what to do to improve their physical health, to reduce the physical dysfunctions. Advise them that after 30 minutes of screen use, they should take a break, which can involve blinking eyes 10 times, moving head forward, backward 5 times each, so the neck strain goes off, moving wrist clockwise and anti-clockwise 5 times each. Then I think other advice which comes, as we said, if they are using chair for screen use, after 30 to 40 minutes of sitting position, take a brief few minutes break, few minutes stand up thing, so that I think you are reduce the chance of musculoskeletal issues. And these kind of suggestions works with adolescent, because we are not taking away technology, and we have a rationale that we want to improve their physical health. Plan gradual reduction, silent notifications, and avoid use 30 minutes before bedtime. And I think there is a rituals, this strategies we have built up to regulate sleep time. Check with the adolescents what are their preferred sleep time is. Like if they say 11 or 10, whatever the preferred sleep time, ask them at least 5 hours before sleep time, they should engage in some physical activity, any physical activity. And 4 hours before sleep time, they should have last drink, last coffee, or last energy drink. 3 hours before sleep time, they should have their meal if possible. And 2 hours before sleep time, they should have quality family time. The whole family should manage that quality interaction. And 1 hour before sleep time, if they can avoid screen use. If the 5-step strategy, out of 5, even if they start following, you will find a change in adolescents' overall use of technology. And 60 minutes of physical activity is recommended, and even adults also we recommend 90 minutes of physical activities, because even geriatric populations are suffering from excessive use of technologies. Even geriatric population also needs 60 to 90 minutes physical activities. And to avoid binge watching, take 10 to 15 minute break after second episode definitely, so that you should not meet the criteria of binge watching syndrome. And for psychological issues, though I understand your clinic setting would be heavy, so you can't go for individual work, but definitely advise them breathing exercise, which can involve simple 5 cycle of slow and deep inhalation and exhalation. Help them to build up leisure time activities to overcome boredom and loneliness. And the technique which generally works with most of the families, what we call digital fasting. And that whole family should decide that at least 30 to 40 minutes they should spend without technology, and that time to be used for offline family based activities, maybe play, maybe communication, or maybe any other things. So that will definitely brings whole family together. That will also bring communication, that will also bring understanding of each other issues. Another thing which you can do, I think, if you want further to work with adolescents, you can ask them to maintain a diary. Diary is like a thought diary which we works to work on mood issues. Now we have built up internet diaries where they can maintain a log of what all online activities they have done in the last 1 week, what are the emotional state when they were doing those online activities, and what were the antecedent to get on those online activities, and how much time they have spent. So on your follow-up visit, if you can just discuss these things also and help them to work on their emotional state without using screen can also give them build up instant felicitation, and they can also be promoted to use other offline adaptive activities. And this is another way to motivate them for balanced use of technology, build up this addiction journal, what when are they using internet and when they are not using internet, so that they can see the difference and build up change in their lifestyle. And this can be change plan worksheet. I think that you can consolidate on their each visit or maybe monthly basis. The what change I want to make, reason they want to make these changes, and their goal for making these changes, and how what the positive and negative results they're expecting. This is digital detox helpline which we runs every Friday, 9:30 to 4. You can share this number also to the whole family members also, because we also run what we call online parent support group also, which we run every Saturday. And parents can see our website, Remains website, to register for this parent support group, so we can help them to address their issues. We can help them to address their other concerns related to the technology use in children, as well as we can help them to improve their psychological well-being also. And for other users, you can share our digital detox helpline number. They can call us on every Friday, and this is all services are free. And these are other helpline number which I think you can share with them. Sometime if they need, they can use it. So overall, if I were to summarize, I think we have worked on individual factors, we have worked on family factors, we have worked on technology related factors, we have worked on general factors like food, other things, and the specific factors like behavioral issues and other things. And if you works on all these factors, what you will achieve is what now we call is digital resilience. Earlier, decade back, we used to talk about psychological resilience, but now we have to work on digital resilience, which is a broad term which includes lifestyle changes, which includes cyber literacy, which includes cyber skills as well as psychological skills also. If we are enabled, if we are build up this digital resilience in our children, definitely they will have less burnout, less cyberbullying experiences, less digital addiction, and doom surfing and other things. But the challenge always remain, even with my almost a decade experience. Still, we don't know how much is too much. Still, we are working on that empirical values for it. And do we have higher degree of social isolation? Is Indian culture is moving toward that, and how we can work towards it? And are we losing out our attachment in real world? And do we have to promote strategies to promote healthy use of smartphone and other things? So I think these challenges remains, but I think all of us works together. Definitely, we will find a solution for all these questions also. Thank you.
Thank you very much, sir, for throwing light on various forms of internet addiction and various forms of detox therapy. It was a very enlightening session. Thank you, sir.
Thank you.
Shall we move on to the next session, panel discussion? Yes.
Yeah, can I have a couple of questions for Dr. Manoj?
Yes.
Dr. Manoj, it was nice listening. Can I, Dr. Amira, can I ask?
Yes, sir.
Dr. Manoj, I think I know that we are trying to sort out the problem. I think the whole point is actually, I know everybody knows this one. We have to try and prevent the problem. I think the only way this can happen is, I think after COVID, we all know that the schools are giving loads of work to the adolescents, even when they are away from the school. I think the first point we have to deal with this is that's where we have to start. I think, honestly, it's easily said than done. I think they should go back to pre-COVID days when they should go by, the physical way of working rather than by doing this online activity. Many of them have been pushed towards the online activity. And as a result of that, they end up seeing so many. And that's where the problem. As the problem, we have to reach out the issue.
Yeah.
I keep saying this in all forums.
Yeah. And I think I agree with you, because nowadays there is a lot of parents also want that we should have go back to the school diary rather than getting messages on assignments on WhatsApp and other things, because that's also becomes the reason for adolescent that I am doing academic works and I need access to the devices and all. But I think, as you rightly said, we have to work We have to adopt very holistic approach, and all of us have to work together with optimistic outlook, so that I think we can build up awareness in all stakeholders.
So as Dr. Vishwanath sir told it, we start from the school administration because they are giving lot of works on mobile, and the students are telling we are seeing mobile for academic purpose. So we have to start from there, I think.
Yeah.
School has
And I think
to.
this we are working on as a Karnataka government policy. We have also suggested, because we had a teachers, we got feedback from teachers also. So we have suggested whether we can go for this kind of change also, as we
Yeah,
suggest.
yes, sir. Yes, sir.
Nabila, you are on
Sharma, can
Kindly mute the audio.
Dr. Sharma, this is regarding the use of chatbot and other artificial intelligence. Nowadays, the parents, they approach the issue and consult before coming to the hospital, or doctors or healthcare workers. They consult chatbot. Recently, day before yesterday, one overseas mother asked me, and he mentioned, why you shared your government's baby. And the chatbot mentioned your baby is perfectly normal. But I personally feel it's an extensive skin disease. Obviously, it is there. And immediately, mother got wild, sir. She didn't even pay my fees, and then she just left up very educated. They had just traveled from Canada. The elder sibling I treated. This has happened, and how this chatbot and artificial intelligence we can, counsel the parents, or will you, discuss this issue before consulting them, sir? Almost all the IT people, they have these issues.
And because now what we have worked, as I started with it, most of the now, since technology is evolving, and now we have AI and chatbot also. So till now we have recommendation only for screen use, but I think we should have some guidelines and recommendation for AI and chatbot use also, for children as well as for the parents also, so that I think they should know what are the do's and don'ts for all these platforms. But still, I think when the milestone still remain, that how we can share this message, or how we can spread this message to the young children for need for offline activities, and how much is too much of AI and chatbot use is. And I think there we require a lot of stakeholder involvement, whether it is school people, teachers, parents, or anybody. So I think that concept has to be discussed at various level. Only then I think this consolidation of how much is too much will happen in children's adolescent cognition also.
Why I raise this question, is there any medical legal issue of the parents or the medical practitioner if we are asking why you have shared these images to the chatbot and getting the diagnosis?
Yeah.
That is what my
Yeah. So I think if I understood right, because nowadays what we are also facing, like most of the parents or most of the patient do also comes with a lot of knowledge. They have already gathered from AI, they have already gathered from other platforms, which sometimes may be applicable to them, sometimes may not be applicable for them, and which sometimes do create a lot of anxiety for them. So definitely there is a need to address this aspect, as you rightly said.
senior person who has got a vast experience like you, how we can tackle this, sir, before itself? We don't want, because out of anxiety by seeing the high five patient from overseas, this happens always with vaccination. Now with the clinical implication also.
I think definitely, I think today we have a panel discussion, so definitely we can have some suggestions from the other panelists also.
I think
Thank
we
you.
are running short of time. We'll move on to the panel discussion. Today's panel discussion is about problematic internet usage in pediatric practice. The panelists are our esteemed faculties, Dr. Manoj Sharma sir and Deepa Janardhan ma'am, and the moderators are Dr. Pradeep and Dr. Navina. Dr. Pradeep is a young and dynamic pediatrician MD of Geet IVF Hospital, Kanyakumari, has conducted over 150 adolescent health programs across Tamil Nadu and received many prestigious awards. And Dr. Navina is consultant developmental behavioral pediatrician with expertise in early identification and intervention of developmental delay and neurodisabilities. She is also interested in adolescent transition, promoting independence and inclusion across developmental stages. Over to you, Dr. Navina.
Navina, please share the screen.
Just a moment, sir. I'll just share this. Can you see the screen? Are the slides visible? No.
Please start slide. You can start the slideshow. Yeah. Thank you. It's a great honor to introduce Dr. Deepa Janardan. She was the treasurer of IAP Kochi and AHA Kerala in 2021. She was secretary of AHA Kerala in 2022, South Zone EB member, and she was the South Zone editor of Adolescent Today magazine. She was the South Zone coordinator of AHA in 2024, chairperson of AHA Kerala in 2025, and right now she is the South Zone Central EB member of AHA. And more than anything, she is a mentor not only for the adolescents but also the adolescent pediatricians, because before we go to any CME, I make it an imperative call to her and get all the latest guidelines from her. And only after getting all these guidelines, I start preparing my own presentation. So over to you, ma'am. Let us have a detailed session. So the first question today is, we are all busy pediatricians right now. We hardly have 5 minutes to see a patient. So in a busy OPD, how can we identify teens with psychosocial problems like problematic internet usage?
Good evening, one and all. At the outset, I would like to thank the organizers, IAP Tamil Nadu and AHA Tamil Nadu, for giving me this great opportunity. And a big word of thanks to Pratik for the kind words of introduction. So coming to your question, it's a very practical one. We often, our OPDs are often busy, and in the busy OPD, finding out mental health issues in adolescents is quite a challenge. So what we use is, any adolescent between the age of 10 to 19 years, when they walk to our OPD, we ask them 3 questions. What are those 3 questions? First question is, how is school going? School is a proxy measure of adolescents' well-being. Next, we ask them, how do you describe yourself as a pretty happy, sad, or stressed person? Or in other words, we can ask, how is life going for you? But I would prefer the initial one because that is easier for the adolescent to give an answer. And the third question is, when things doesn't go well, what do you do? Whom do you go for help? That is, what are your coping strategies? So these 3 questions, how is school going? How do you describe yourself? And when things doesn't go well, what do you do? Whom do you go for help? This gives, if anything concerning comes out of these 3 questions, I'll tell them I want to talk to you in detail. So as per mutual convenience, we schedule an appointment and go for a detailed heads or shapes assessment.
Going on to the next question, ma'am. We all know that typically I myself have teens at home, and whenever we ask them something, they are very reluctant to open up. So they often shrug and they don't answer. So they are naturally guarded. And since teens are very reluctant to open up, do we have any technique to help them share their feelings with us? Any technique to help them?
Yes, Pradeep. Actually, what we need is an adolescent-friendly setting. So what is an adolescent-friendly setting? Starting from the waiting area. The waiting area of an adolescent-friendly setting should not have toys, should not have dolls or cars or anything like that. Instead, should have a some sports magazines, some film magazines, or some fashion magazines. And what is displayed on the TV should also be something like an IPL or anything like that. And the front desk staff should also be trained to deal with it in an adolescent-friendly manner. And if I want to tell you a secret, I first need you to ensure me two things. One is privacy and second is confidentiality. So which and auditory privacy should be ensured. And when I start talking, I first tell them whatever you tell will be between us unless something comes up that can harm either you or somebody else. So first we ensure the privacy and confidentiality. Next comes seating arrangement. I don't want to tell to person sitting across the table. I want to talk to in the minimum volume, so I want that person to be sitting by my side and ideally at the same height, not on one person on a high chair and other on a small chair. If body language matters, if the other person should feel that you are interested in what he's talking, especially when he's sharing something very emotional, very sensitive. So your body language matters. You should maintain good eye contact, and you should be sitting with a open hands, not to sit with a folded hands like this. And another important thing is active listening. So how does the other person know that you are listening actively? That is by reflective listening. So what do? That is when they speak something in direct speech, you turn it into indirect speech and say. For example, if he's telling, my parents recently got separated, I'm broken, actually, I'm overwhelmed, I can't study, I can't concentrate, and I actually failed in an exam. So what, if you say, I understand, he will immediately understand that you didn't understand anything. So instead, you must have had a real tough time. But I really appreciate that you could go through all these things. So that is the way we say, so that is without adding any judgment from our side. Next is open-ended questions. So how do you ask open-ended questions? Questions that can give a descriptive answer rather than a single word answer. And then our attitude should be a non-judgmental attitude. So if a girl says like, last year Rahul was my boyfriend, but then after some time I felt bored, so now I'm roaming with Anil, and at the same time I'm also having Matthew on my as benching. You should not ask what, because that is a judgmental attitude. Whatever they say is okay for you. So that should be your attitude. And when we talk to the adolescent, what we want is that we want them to open up. We want them to know. We want them to tell us both the positives and negative side of them. So for that, we have to have a non-judgmental attitude towards the contents of the speech. If that person says, I'm a very good singer, I got prizes in the state and national level, wow, when you say that, then they will tell you only the positives. But if you want to hear the positives and negatives of them, we have to praise the communication skills. You give me such a clear picture of your home. You speak so well. Thanks for sharing such sensitive matters with me. Thanks for trusting me. So these are ways we can praise the communication skills. And last and most important one is empathy. Empathy should be there, both not just in your words, but in your eyes, in your body language, in the voice, your tone, everything, empathy should be reflected. So that's the secret behind making an adolescent open up to you. Thank you. Pradeep, you're muted.
Yeah, Naveen, next slide, please. So we often have these two traditional frameworks, the heads and the newer one, shades, ma'am. So do you think that one tool is more relevant, more effective than the other?
Pradeep, actually, as you said, heads is a traditional psychosocial assessment tool for adolescents. But the problem with heads is it starts with home. And most of the time, many sensitive issues usually stem from home. So when you start with a sensitive thing, we lose the rapport. So that is why the modification of heads came, which starts with strengths of the adolescent. When you ask, can you tell me something you enjoy, something you're proud of yourself, or how would your best friend describe you? That shows the strength of an adolescent, which everyone would be interested in sharing. So that helps in building a better rapport. Also, when you ask these patients, when they have issues like PIU, we are looking through the lens of a high-risk behavior. But we want to see the adolescent with a holistic picture. So shades helps in that. Moreover, head covers only one emotion, usually the sadness or the depression, whereas shades covers more emotions. It covers anxiety, stress, low self-esteem, everything will be covered in shades. So on the whole, I prefer shades over heads.
The next step, yeah. So, ma'am, you did mention about these open-ended questions. I think they are the key tool in helping an adolescent open up. Can you tell us more about these open-ended questions that are relevant to problematic internet usage?
Yes. Open-ended questions, actually I told you, they are questions which invite answers in a descriptive way. They give paragraph answers rather than a single word or yes or no answers. So when we start, for example, if this PIU comes under activities of shapes. So when we start with a general topic and go to more specific. So I'll just illustrate some examples, some questions which you can use. So regarding general hobbies and screen balance, we can ask questions like, can you tell me some things you do for fun? Navina, so what do you do for fun these days? How have your hobbies changed since last year? Then we go, what do you usually do? What do you usually do, like to do online? And Navina, and how does your screen time fit with your online other hobbies? Now coming to social connections and digital life, we ask, what do you enjoy most when you spend time with friends? How have your friendships changed recently? Which apps or platforms do you spend the most time on? And whom do you usually interact with online? Regarding related to internet use, we can ask, what kinds of stress or pressure do you notice related to being online? When do you feel more stressed about your internet use? How has your internet use affected your daily routine? And what changes have you noticed in your sleep or energy levels? So problematic internet use, we can discuss under 4 domains. One is uncontrolled video gaming. Next is social media use. Third is pornography viewing. And last is information binging. So for here, no, all these things are a bit offending things because these are all high-risk behaviors. So in order to prevent the adolescent from getting offended, we start with a general question. That is something maybe peer-focused or something related to environment. And then we have a transition question, and then we move on to a personal question. So let's see under each heading how it goes. So for peer focus, you can ask, and for uncontrolled video gaming, what do your friends enjoy most about gaming? For transition, we can ask, how similar or different is your gaming compared to your friends? And for the personal level, we can ask, what does your gaming time look like on a typical day? For social media use, the peer question would be, how do Gen Alpha usually use social media? Transition, where do you see yourself in that? And for personal level, you can ask, what happens when you try to cut down? Information binging. Do you know what this is actually? When we try searching something on the Google, something more interesting pops up. And then we click that. And from there, we go endless. So just for looking something worth 5 minutes, we end up watching for 2 hours. We get a lot of information, but then a lot of time we spend on that. So this is actually information binging or rabbit holing. So the peer question would be, what do your friends say about getting stuck in endless content? And the transition will be, how similar or different is this for you? And the personal question will be, how do you feel after spending a long time this way? And pornography being a more sensitive topic, the peer focus question will be, how do teens these days usually come across adult contents online? Transition, where do you see yourself in this? And personal question will be, how do you feel during and after viewing?
So right after we do all these things, we have this question, ma'am. How do you really diagnose this problematic internet usage? Because things are very vague. Are there any screening tools that we can use to make a diagnosis actually?
I have a disclaimer, like we don't have a DSM-5 criteria or ICD-11 criteria for PIU. So what we do is we just look for the usual symptoms of addictions. Next slide, Navina, please. So first is preoccupation, like Dr. Sharma was telling. What is preoccupation? If I'm addicted to web series, when I'm sitting in OPD also, I'll be thinking about the characters in the web series. So that is preoccupation. My mind is always thinking about that web series. Now withdrawal. To understand withdrawal, I would tell like, suppose you're watching an India-Pakistan cricket match. It's the last over. Only 3 balls remain and India needs 10 runs to win. Suddenly the power goes off. What will you feel? So withdrawal is, if a child is addicted to something and there is a withdrawal, there's an extreme form of this that happens. Tolerance is like, today I watched my web series for half an hour and I feel satisfied. Tomorrow I need to watch for 1 hour to feel satisfied. Day after tomorrow I may have to watch 4 hours to feel satisfied. So that is tolerance. Unsuccessful attempts to quit. Loss of interest in previously enjoyed activities. Continuing to use despite problems. Deceiving family members or others about the time spent on activities. My mother asked me, when did you sleep yesterday? I tell 9 p.m. Actually, I slept at 3 a.m. watching social media. So that is deceiving family members. and risk having jeopardized a job or relationship due to the same. So that is, if 5 of these 8 are there, we say there is addiction. So the 4 C's and 5 D's, actually sir had added one more C, 5C to that. So these are the symptoms, cardinal symptoms of addiction: cravings, compulsions, loss of control, and continuing to use despite consequences. But any guess what are the 5 D's? When you have a temptation, how do you resist it? You can resist it with 5 D's. When you see something you like most, an ice cream, how do you resist that? Take a deep breath, drink some water, delay, okay, I'll have it after some time. Distract, think of something else, and discuss with someone. So these 5 Ds helps in avoiding temptations or dealing with the temptations. So we have some screening tools for PIU. The first one is problematic and risky internet use screening scale or CRIS scale. And the next one is Young-Kimberley Internet Addiction Test. So CRIS scale is used in adolescents. It has around 18 questions, and each question is scored from 0 to 4. And it is it's examined under 3 subscales. One is social impairment, emotional impairment, and risky or impulsive internet use. And a cutoff score is 25. Next slide. Young-Kimberley internet addiction can be used in anyone above 13 years. That is, it's used in adolescents and adults. It has 20 questions, and each is it can be scaled from 0 to 5, and above 30 is considered normal.
Okay. So, ma'am, this I think you've already we have already seen. Do these pediatricians have any role in management part, ma'am? Can you please guide us regarding that?
Yes. So after you diagnose PIU, we need to screen for comorbidities. So many times PIU can be associated with depression, anxiety, ADHD, and other symptoms. So that has to be screened for. Physical, yes, one of the commonest causes of headache and neck pain among adolescents these days is over excessive screen use. So anyone who comes with headache, please ask about the screen time. Likewise, there can be obesity, sleep problems. So all those things should be screened for. And safety, yes, we have to assess for the safety, like cyberbullying, online predators, visiting dark webs, or some games like blue whales and all, which causes harmful challenges are there. So such situations can be, such safety issues should also be addressed by the pediatrician. Now coming to family, many times the parents think that it's because of the lack of care or lack of discipline that the child meant for these addictions, but we have to explain the biology behind digital addiction. What is that? That is a dopamine loop. So what is dopamine loop? When you're doing an activity, it is not actually the activity per se that creates the trigger or the dopamine release. It is the anticipation of a reward. And what kind of reward? The reward is a variable reward. What does it mean? When you scroll down, you might sometimes end up having a boring ad, or sometimes a very interesting video, or sometimes lots of likes. So that reward is variable, and anticipation of this reward creates dopamine. What happens once you receive the reward, the dopamine levels drops. And once it drops below a baseline, it creates a dopamine deficit. And then we need to have an urge to do another activity. So that creates a vicious cycle, and we are in the dopamine loop. So this has to be explained to the parents. Next is something like called digital food pyramid. We can explain this as a analogy to the food to the parents. So for example, every digital content you can compare it to food like highly nutritious, less nutritious, and toxic. So highly nutritious food are something academic, something research, something creative, or connecting with family and friends. So they are all good nutritious food or nutritious content. Now, nutrition is something equivalent to empty calories. That is like infinite scrolling. We just keep scrolling, or some unboxing videos, or watching reels. These are all empty calories. And what is toxic or hazardous is what I have already told you regarding safety issues. Cyberbullying sites, or dark webs, or online predators, or sexual abusing sites. All those things are toxic and has to be filtered off. Next, we like to tell the parents to formulate a family media plan. So family media plan, all the family members has to sit together and discuss and decide and define certain screen-free zones in their house. That can be something like dining table, kitchen, or bedroom, something like that. It can be customized to each and every family. Also, they can have screen-free times, 1 hour before bedtime or while driving, likewise. So this has to be agreed upon by all the family members, and nobody should use during these screen-free zones or screen-free times. Then we have the 1 hour rule. What is 1 hour rule? You use the screen for one time, you do some offline activity, physical activity or social activity for next 1 hour. Now, curated content. That is, when we go into the internet, many times we feel that it is not we, somebody else who is deciding what we should watch. Why it happens? Because there are algorithms designed to that decide what we have to watch. So what we have to tell ourselves, our teenagers and their parents that it should not be the algorithm, but we who decides what we should watch. And how do we do that? That is by using filters, filter of the toxic contents, and whitelist the good nutritive value things. And the parents has to co-view with the child. What should they do? They should sit with the child. If a child is playing a game, if you sit by the side and ask about the characters in the game, or how to score and why this child prefers this game over other, the child will answer. But if you ask about the cool things, they may not even respond. They are in a state of trance. And next is coordination of multidisciplinary care. The ultimate treatment for PIU is cognitive behavioral therapy. For that, we have to refer to a psychologist. Pharmacotherapy, yes, if there is depression and anxiety, treatment has to be given. And we need to liaison with the school counselors to address any stress in the school, academic stress or cyberbullying, so as to prevent it relapse. That's it.
So this is the question which is often asked, ma'am. Even I had a call from a pediatrician recently, and he was telling me that his own son was having this issue. He refuses to go to school because he's addicted to gaming. So when should a pediatrician refer to a specialist? Can you clarify me?
Yeah. As I told, the definitive treatment is cognitive behavioral therapy, for which we need to refer to a psychologist. Navina, next slide, please. And when there is comorbidities like severe depression, severe substance use disorder, or severe anxiety, suicidal tendencies, we have to refer. And significant functional impairment, as you told Pradeep, when there is an academic failure, family conflicts, sleep reversal. Some kids, they sleep throughout the day and will be awake throughout night. So such are the conditions where we have to refer.
So, ma'am, even we had this question, even we have it in the chat box also. So, is there any role of AI? Because Aram Chandal sir himself was telling me that initially, because of AI, one child had committed suicide. He had looked up how to commit suicide, and that AI had guided them. So, what is the currently AI's role in this problematic internet usage, ma'am?
I would say AI is very good, and I would say AI is very bad also. It's a double-edged sword. Actually, on the bad side, if you look, AI can create addiction. AI is the architect of addiction. They have engagement algorithms. What are engagement algorithms? Actually, this platform, these algorithms help the platforms to identify the exact contents that keep a particular child hooked on. So they know how to create the variable rewards and the dopamine loop on. And next is predictive personalization. What they do, they identify the vulnerabilities of the child. Some child actually may be wanting for the social recognition. So these vulnerabilities of the child are identified, and the child are given empty digital calories or empty calories, and which this prefrontal cortex of immature prefrontal cortex finds hard to resist these empty calories. So they keep hooked on. So engagement algorithms and predictive personalization create addiction. But at the same time, on the positive side, for early screening and diagnosis, AI has a big role. It can recognize the patterns and helps in early identification of PIU with machine learning models. And sentimental analysis helps in identifying the comorbidities like depression, anxiety, and now AI as a digital guardian. Context awareness filtering. The present-day AIs can differentiate between harmful contents and useful contents and can filter out. Adaptive restrictions, they can tighten the boundaries. So if a child is having a surge of impulsive usage or late night checks, it can tighten the boundaries and restrict the use. So it can act like a parent. And last is AI-powered therapeutic support. The CBT chatbots like Visa, Wobot, they can help they can do actually the cognitive behavioral therapy like cognitive restructuring, and it's available 24/7. So between the weekly sessions, if the adolescent feels an urge to scroll, he can resort to these chatbots and use it. And also we have the virtual reality exposure therapy that helps in controlled usage. For gamers, it provides a simulated environment where they can practice controlled usage and walk away from the game while they simultaneously monitor the heart rate and craving levels. So all these things are possible with AI.
What is the take-home message for us pediatricians?
Actually, the present day teenagers, whether it is Gen Z or Gen Alpha, they are born in the digital era. So I would say rather than the quantity, it is the quality of the digital contents that is more important. So this statement which I put over here is by Dr. Michael Rich, who is popularly known as a pediatrician. He's from the Boston Children's Hospital, USA. And he states, we have to teach our kids to use these gadgets as devices, not toys. We need to use it cautiously, wisely, and more importantly, responsibly. Thank you.
So that was a wonderful session, ma'am. I invite my co-moderator, Navina, to handle the doubts from the audience and also give her a feedback about this. So others can unmute themselves and ask their doubts, or you can post it in the chat box. But this was really wonderfully curated. Yes.
Hey, good evening, ma'am. Regarding digital de-addiction, actually what it is, ma'am, how it is done, actually.
What is that?
Digital de-addiction, is there anything like that? And how exactly it is done, ma'am? When, where it is done?
Basically, it's done by psychologists, and basic treatment given is cognitive behavioral therapy. So what is cognitive behavioral therapy? Is like when you have a problem, sometimes you feel it's overwhelming, you can't handle it, you can't move forward, you're stuck. So sometimes somebody asks you some simple question that change your thought process and the whole problem is nullified. So that's what happens with cognitive behavioral therapy. And that is provided usually by psychologists. So once you identify there is an addiction, it's better to refer to a psychologist for cognitive behavioral therapy.
Is there any centers like the Limans?
Yes, Shut Clinic, they do that. Mostly psychologists do, but then Shut Clinic is one specialized, and I think they have online also. It's available.
Online also is there, ma'am?
Yeah, they have. And
Madam, what I think is like alcohol de-addiction centers, mobile de-addiction centers will come soon in several parts of our country. I think that will be a profitable one also.
We still think there is a physical structure like that existing. Is it so, ma'am, really? Like a alcohol de-addiction center, I thought it was physically existing. Is it?
Actually, what Dr. Manoj is running is also it's a physical one in William Hands, actually.
Oh, okay, ma'am. Thank you so much. In Tamil Nadu and Kerala, ma'am, other referral centers? Because many of the parents even don't know how to, where to refer and how to do that. That's why.
Yeah,
they have to refer to a psychiatrist only, I think.
Ma'am? Sir?
Better ma'am will tell. Psychologists do cognitive behavioral therapy usually. Specialized thing, I think Shut Clinic is not one I am aware of.
Okay, ma'am. CBT, how it plays a role? Can Dr. Manoj sir, can you please explain a little about it?
Sorry, Manoj sir is not there.
Okay, sorry.
I think I can tell you that cognitive behavioral therapy is basically altering your thought process so as to change your behavior. So some questions they ask will make you think and and reach a different conclusion. So many of your wrong notions can be questioned. That is basically how it is.
But for that, how to get the cooperation of the adolescent, ma'am? Because for the thought process to be changed, we need the cooperation of the adolescent.
Yes.
They have maturity to work on themselves.
That is what I told the initial techniques of counseling, and our first slide which I mentioned was that actually.
Okay. Thank you.
The adolescent only setting in.
Sorry to interrupt, Dr. Anbu.
Yes, ma'am.
So actually, cognitive behavioral therapy is not a one-off session. It's done in a series of sessions.
Okay.
The duration will depend upon the severity of the addiction in the adolescent.
Okay.
So it may take up to 3 months, even 6 months. So I know a child who was almost had it for 6 months as an inpatient. Yes. So maybe like the Shut Clinic, what they do. And maybe mild to moderate, they may undergo like OP sessions. So the thought process or the behavioral change doesn't come on in one session. So
okay, where is the patient admitted, ma'am?
Pardon me?
Where was he admitted? Which place?
Oh, the patient I'm talking about, he was in he's in Bangalore and he was admitted in US actually. He was there as an inpatient for 6 months and then
Okay.
he was treated in Seattle. There is a center.
That's what I want to know. Whether is it they something is there like that there in Tamil Nadu or Kerala like that, ma'am?
Tamil Nadu or Kerala, we don't have
We
inpatient,
don't
but
know where to
actually the medical colleges recently have started this de-addiction centers. But like how far they are functioning effectively, I'm not very aware of. I heard of
Shanti, what about the government centers? Na? They're claiming that they're from.
Yeah, actually, every medical colleges has to have a de-addiction center, a separate one. So I think it comes under the Department of Psychiatry.
Okay, ma'am. Alcohol de-addiction center is already there, ma'am. Digital
Yes.
de-addiction also it's coming up, ma'am.
Yes. It is to be started in every medical college.
Okay.
This
Thank
is a question to Dr. Deepa. See,
Yes,
like
sir.
I'm a neonatologist. Like we have a Parker's hypothesis where the adult onset disease is programmed in a IUGR baby or a preterm baby. Now I can see that the least birth, the age is 3 to 6 months. The mother or parent, they are giving during the rounds time, bribing the child. Is there any programmed in the future brain of babies, our generation, to use the mobile by default?
I didn't get that part actually. Means how they learn. Is that what you meant, sir?
Yes, by default. See that this hypothesis is by default. We know the program adult onset disease. Like that, in future, these children might have been given a default priming of their brain, growing brain, to use or to ask for demand for this by nature, or it is a man-made disease.
I told
Sir,
us
you
that
are
there is a
asking
dopamine.
by birth. By birth itself, as in future generations, children will have such a craving. You are asking like that.
That is what, my love, some epigenetic factors,
Yeah.
the genetic factors influencing the growing brain.
Maybe we can research on it, sir.
No, I strongly believe, because this adult onset disease, we are facing it very badly. The same principle apply for this growing brain if they exposed to this kind of gadgets, either man-made or by the priming of the Almighty or whoever it is. So that's what my mind says.
Actually, to support what you say, I would say one is we have studies of early exposure to screens and associated with autism. Likewise, in substance abuse, we say for alcoholism per se, if you introduce alcohol to a person before 21 years of age, there's a 5 times more chance of becoming an alcoholic compared to somebody for whom alcohol is introduced after 21 years. So your hypothesis is quite possible, so we can do research on it actually.
I need people like you or Sharma Shah can do some research on that, thinking that there is some kind, definitely there is some role, because the early exposure is approaching fast in a small babies, which is
very true.
Which we don't.
In this connection, I will tell one incident, sir. In my clinic recently, I saw a 8 months old baby who was crying incessantly. Their grandmother was bringing the child. I asked the grandma why she is crying. She is telling her mother has gone away. Then for that alone, she is crying. No, she has taken the mobile with her. So the 8 months old baby is craving for a mobile phone.
So this
So situation is like that.
In future, we can call it as a man-made disease.
Maybe we should start for the pre-conception period itself. We have to give counseling sessions to the future parents.
Take a good lead, madam. This is need of the hour.
It is definitely a man-made disease. There is no doubt about it. I don't think. I think it's basically we are spoiling the next generation for sure. Until we act now, I think it's like Western countries. They've bred all the junk foods and they're seeing the obesity now. And then as a society, if we don't act now, as a professionals in the government, if we don't act now, and basically we are creating this epidemic, and we never know what sort of problem we are going to see in future. Already Dr. Manoj Sharma's listed 10 syndromes. We may be seeing 50 syndromes. I don't know. I'm just saying this one. I think we have to act. I think instead of talking about this, we have to act now. This is what I think. I feel that as IAP, as AHA, as entire society have to act now. I
Sir,
think if the Western countries can ban these all the social media and all these things until the adult age group, why can't we do this? We should do this.
So there are some issues with that also, sir. Like because
yes, there are some issues with that.
Our adolescents, if you ban, they will go for other ways. For example, if you say you have to provide an Aadhaar card, they will use parents' Aadhaar card.
No, I don't understand, but we should. We should start somewhere. I don't think we should start somewhere. That's the only way. No, I'm not saying total ban. We should start slowly, and we should reach some target. Otherwise, we are never going to win this war. That's for sure.
These children are very smart, sir. If you block one way, means they know some other means.
No, I do understand. I do understand, but we should start somewhere.
Yeah.
We can't excuse us.
We have to act. This is the time to act.
Yeah, actually, if there is some legal measure, there will be some way, because if you ban driving before 18 years, there will be only very few who does that, but many people will be protected because of that. So some legal measures also will be useful actually, but it has to be. It's also a double-edged sword. Has to be done cautiously.
Basically, we should create, a school which is not giving any sort of online activities away from school, and we should give them more time to engage socially at school. These are the simple ways we can start. I think we keep saying what they should not be doing, but we are never giving an option what they should do. When we say we should not ask them, we should be asking not to do this, not to do this. We should try to give them a solution. We are not doing that. That's a problem.
Rightly said, sir. Rightly said. Whenever mothers are asking me, they are giving a mobile as a bribe to engage themselves in kitchen work. I have to say they have to have something else other than the mobile phone, some physical activity. So
they can involve them also in kitchen work, sir.
The parents have to spend time with adolescents. The teachers have to spend time with adolescents. The society have to spend some time with the children. That's the only way. If we are not doing this, they don't have an option there.
Everybody is telling, I have no time, I have no time. That is the answer from the parents.
Anybody else?
One more thing. But if the child is currently engaged in screen activities, how to get them out gently instead of scolding and asking them to shut down immediately? Any steps to take them out?
That is what I told.
Or when is the right time to talk to them?
It's a very
Regarding the, yes, ma'am.
Yeah, that's a very relevant question.
Ma'am, when to ma'am?
I didn't hear the last part of the question. But what I would say is, if a child is watching a video or playing an online game,
Ma'am, most of the times when the child is engaged in watching binge screening only, parents scold them and ask them to shut down immediately and start studying. Instead, how to take them out gently, or what are the steps? At the time when they are engaged in screen, how to get them out gently instead of scolding.
Yeah. So what the parents have to do, that's what I told. When you are watching a cricket, the last minute, when we are on the toes, suddenly the power goes up. What do we feel? The same, an intense form of such feeling the kids will feel when you suddenly snatch away the mobile. So what they have to do is, they have to sit by the side, watch what they are watching, and ask them about what they are watching. Don't ask them about the happening at school or the marks or studies or anything. Just ask them about what they are watching, if it's a game, about the characters in the game, how to score, why the child prefers that game over other games. The child will definitely answer. They will look into your eyes and answer. Then slowly you move to another topic, and then slowly bring the child out of it. First, talk about what the child is watching. Please try this next.
Nice explanation, ma'am. Thank you, ma'am. Thank you. Ma'am, what's the right time? At the time of watching screen, we cannot, advise. What's the right time to advise regarding this, and how to, tell them gently regarding this problematic?
I would say, please don't advise them. Ask them queries. When your child is watching, you will have some queries in your mind. Ask those queries to your child when he is in good mood. When it's a quality time you're spending with your child, when he's about to sleep without screens, when he's listening to you, that time just ask your queries to him. So that he will also think about the queries in your mind, and he will reach a decision on his own, which he will respect and will do. If you tell something to them, your child is not going to listen to you. They don't want advice. They don't want suggestions. But if you make them, they will take it. And it should be their decision, their ideas, which they respect.
You mean to say when he is in most receptive mode or in good mode?
Yeah.
Okay,
I'll tell you one example.
How
My
to get that
daughter,
connectivity to take them out for a ice cream parlor and how to make it practically that
for
good
me,
mood.
a quality time will be every night when my son is about to sleep. I'll sit by his side, and then it's a quality time where I just put him on my lap and then talk him about what happened. I'll first tell what happened in my hospital, what happened, how the day went for me, and then he will start opening up what happened in the school today, that day. So that is how we have. And one example of what I said, I would say like my daughter is doing BTech in Coimbatore actually. So one day she called me and told, Amma, next year I would like to move out to a house outside the campus. So I asked her, our immediate response will be no. For an adolescent girl moving outside and staying alone, answer would be no. But I swallowed that no and asked her what happened. So she said, in my room, we are 4 of us, and all 4 of us have different timings. We study at different times. So my sleep is affected, my study is affected. So genuine reason. Yeah. Then she told me, I have one more reason, Amma. What is like, I just want to explore how it is living alone, buying groceries, paying rent. I just want to experience that. Again, a genuine reason for the curiosity of an adolescent. Then I told her, what you said is absolutely right. Both the reasons are genuine, but I have a concern. You're staying outside the campus. It is a deserted area, hardly any shops, hardly any houses. And if someone comes and knocks on the door in the midnight, what will you do? She didn't tell me anything. She kept the phone. And next day she called me and told, Amma, I have asked for a single room in my hostel. I think you got my point.
Yeah, ma'am. I mean, nice. Again, nice suggestion. Instead of saying immediate no, you made her understand what it is.
Yeah, first I made her talk. I made myself understand what are her concerns, and then I expressed my concern and made her think.
Okay.
And she took the decision.
Oh, okay. Nice one, ma'am. My question is whether any physical stimuli will add on to the good mood of the child. That's why I'm asking practically, like or a good food or some
That should not be
AC like
bribing.
that.
That should not be bribing.
Usually, pet animals will attract them. Children will be fond of pet animals and taking them for a walk.
Oh wow! Yes.
The other interest, yeah. As sir was telling, we should, when we are taking them away from something they like, we should provide an alternative. So something they enjoy.
What, ma'am?
And that is here. When we are taking something away from them, we should provide them an alternative, something they enjoy, something they like doing.
I think they can be better placed in some extracurricular activities which they like most,
Yes.
like dance, sport. They should enjoy it. That's the thing.
Thank you very much. That was a wonderful interaction from the delegates.
Thank you so much,
and I would like to invite our Vice Chairperson, Dr. Lakshmi Shanti ma'am, for a vote of thanks.
Thank you, Amoda. So it was a wonderful session today on the need of the hour topic, which is problematic internet use, which we're seeing in all the children and adolescents day in and day out. And there was an excellent presentation by Dr. Manoj Sharma. So thanking him in absentia, he had to leave early. And thank you, my dear friend, Dr. Deepa Janardhan, who gave a very good insight into how we have to deal with these adolescents when they come to our clinic and also provide anticipatory guidance. I thank IAP TNAC President, Dr. Somasundaram in absentia, our dynamic secretary, Dr. Narmada, our treasurer, Dr. Rajkumar in absentia, and our very energetic Vice President, Dr. M.S. Viswanathan, sir. He was till the end. He shared all his inputs, and I still remember the Triple S school program that I did with Viswanathan and Dr. Jalil, sir, here in Coimbatore. So maybe from IAP TN we can devise some school programs similar to the lines of Triple S, so that we can deal with these digital addiction in schools and help these adolescents out. So I thank all the delegates who joined for this program and all the senior Dr. Jalil sir, Dr. Parimala ma'am from Trichy, Dr. Jay Shri Lavanya, and all my friends who connected to this important meeting. So it was a wonderful session with good interaction. So thanking you all.
Shanti, I think the comments which are coming up, you have to put it in the common group. Then I think people will be. This is a very, very good session. It has to be useful for the people. I think we have our YouTube video, so that will also be useful for for everybody.
Ma'am also given many suggestions. So I think that can also be put in the
YouTube. This thing, yes,
yes. It's already recorded, so it will be available for you.
For them, everybody. Yeah. Okay.
So thank you.
Thank you, Dr. Deepa. It was really nice. Yeah. Thank you.
Good night.
Good night, sir. Good night, sir. Good night, everybody. Yeah.
Thank you, Duban.
I was quite confused. And whether this PIU is meant for pediatric practice or the adolescents. It should be for the adolescents.